Hi guys, welcome to my channel Learn in Minutes. Today I would like to focus on my field of work, that is periodontology. Majority of private practitioners, up to 92%, perform phase 1 therapy, that is scaling, on their own, and more than 50% fail to take the periodontal treatment further by referring to a specialist periodontist. Most often, the knowledge update regarding advanced periodontal procedures among general dental practitioners is limited. Therefore, today I would like to enlist the various treatment modalities which might require a consultant periodontist and hence improve the referral relationship of the general practitioner and the periodontist. When a patient with gingival issues and concerns walks into your clinic, always spend at least 2 minutes to assess all periodontal parameters such as gingival status, pockets, mobilities, furcation involvement, recession, or any underlying systemic condition. Once you diagnose, then guide the patient to the right treatment protocol if surgical or non-surgical therapy is required. Most routinely performed therapy is the non-surgical periodontal therapy, and it has been stressed even in the AAP treatment guidelines that periodontal health should be achieved in the least invasive and most cost-effective manner. This is often accomplished through scaling and root planing and other adjunctive therapies in patients with moderately deep pockets. Scaling and root planing is a careful cleaning of the root surfaces to remove plaque and calculus from deep periodontal pockets to smoothen the tooth root and remove bacterial toxins. Scaling and root planing is sometimes followed by adjunctive therapy such as local delivery of antimicrobials, systemic antibiotics, post-modulation as needed on a case-by-case basis. Most periodontists would agree that after thorough scaling and root planing, many patients do not require any further active treatment. But the majority of patients will definitely require ongoing maintenance therapy to sustain health. However, non-surgical periodontal therapy does have its limitations, and when it alone does not achieve periodontal health, surgical periodontal therapy may be indicated to restore periodontal health. As in a case like this that has deep pockets, vertical bone loss, mobility, furcation involvement, surgical periodontal therapy will definitely follow a non-surgical phase. Periodontal surgical phase includes periodontal flap surgery and regenerative therapy. Some deep pockets do not resolve just with root planing. These can be treated by open flap debridement. Other indications for reflecting a flap could be bone contouring in case of irregular bony architecture or negative architecture, or to treat bony defects such as craters, vertical bone loss, grade 2 furcation involvement amenable to grafting and regeneration. During this procedure, membranes, bone grafts, tissue stimulating proteins can be used to encourage body's natural ability to regenerate bone and tissue. Periodontists are often considered the plastic surgeons of dentistry. Periodontal plastic surgical procedures like gingival augmentation procedures involving single or multiple teeth, either to increase the width of attached gingiva or to cover exposed root surfaces, can be treated using a connective tissue graft or a free gingival graft, with or without coronally advanced flaps, grafts and membranes. Other techniques such as laterally positioned flaps, semilunar flaps, etc. can also be used to treat gingival defects. Next, under periodontal plastic surgical procedures will be crown lengthening for single tooth in case of inadequate tooth structure to facilitate crown placement, or multiple teeth to treat a gummy smile that can be achieved either by gingivectomy or by apically displaced flaps with or without osteoplastic procedures. Black triangles too can be aesthetically corrected by a periodontist using hard and soft tissue grafts or both in conjunction with coronally advanced flaps. Ridge augmentation procedures such as vertical ridge augmentation or horizontal ridge augmentation can be accomplished using hard and soft tissue grafts, membranes and growth factors. Socket preservation is another procedure that comes under the scope of periodontology. Apart from these, pre-prosthetic surgical procedures such as vestibuloplasty, ridge contouring using alveoloplasty, alveolectomy, elimination of unfavorable undercuts, reduction of tori, etc., and removal of redundant soft tissue can be referred to a specialist. In the field of implantology, periodontists specialize in placement of implants and are well versed with hard and soft tissue augmentation of the peri-implant tissues. Also, treatment of perimucositis and periimplantitis falls within the scope of periodontology. Finally, other minor oral surgical procedures that can be included in the list are frenectomy, is the removal of bulbous frenum or freni causing recession, hampering tooth movement, diastema, etc. Operculectomy to expose partial soft tissue impactions of third molars, gingival depigmentation using scalpel laser burrs, surgical exposure of unerupted teeth for orthodontic treatments. Therefore, we see that general practitioners have a responsibility to screen patients for periodontal diseases, to make a diagnosis and institute a treatment plan with a defined therapeutic goal. Regardless, to say that the mainstay of successful therapy will always remain regular maintenance and a recall checkup by the consultant periodontist every 3 to 6 months for all periodontitis patients. That's all for now, guys. Have a good day. Thank you.